Yes, we can hear you. So the
Thank
floor
you.
is yours.
Thank you for having
Welcome.
me. So I'm Alison Curfman. I'm not sure what Tomasz just said to introduce me, but I am located in the United States. And he asked me if I could come talk with you guys about, navigating a pathway of designing an innovative model and then implementing it. And so I want to share with you kind of the journey that I've been on to really create a new product for pediatric patients and focused on the children that need care the most. So to start with, I'm going to share with you the origin story of our company, Imagine Pediatrics. So I trained as a pediatric emergency physician and spent most of my career focused actually on complex pediatric patients, and have noticed that traditionally there's a lot less innovation that's dedicated to the pediatric space as compared to the adult space. And I always felt that when I was seeing patients in the ER, there was a very significant disconnect between the resources that these children needed and what they had access to. And I really felt that we could do better, that we could really consider using technology to help expand access to pediatric care, because I was seeing so many children that were, coming to the ER or for the emergency setting for care that did not need emergency care. They just weren't getting access to what they needed as an outpatient. And on the other end of the spectrum, I would get calls from small hospitals in rural areas who would sometimes have a very sick child and try to manage them remotely over the phone to get them to a safe level of care. And it seemed like adding video technology was a very obvious step to help improve that access to the pediatric expertise. But there was a reason that nobody was really using virtual care at the time, and that was because there really wasn't a payment model for it. So I started working on developing a research network to try to start evaluating best practices using telemedicine and digital health as a tool. And so I became very involved with how we kind of map out what health policy should look like with telehealth. So I started my a role at Mercy Hospital, which was a large regional health system. And I was working in their emergency department, and I was also directing all of our virtual care programs for children. And we decided to start our programming with a program for complex pediatric patients because the population is a very small portion of pediatric patients, but they account for a massive amount of spend. And we hypothesized that there was a pretty significant impact that we could make by focusing on these children and really helping to coordinate their care. In addition to their spend, which comes from a lot of inpatient stays and time in the hospital, it's really driven by a very challenging system to navigate that these parents have to deal with. And on the right is a kind of a mind map that was published in Pediatrics that was written by a mom of a complex child. And so they're trying to navigate multiple specialists, all the different services, while also trying to maintain their own employment and potentially take care of other children. And so these patients really struggle to get everything they need and to stay under optimal control. So we had a hypothesis that if we were to invest a significant amount of resources into supporting these families and their children, that it could translate to true financial value by helping improve their health outcomes and helping them stay compliant and out of the hospital. And so we ran this program for about 2 years and expanded to 5 states across the Midwest and had several hundred kids in the program. And sure enough, we found that just by providing more support for these families, which was done virtually, we saw a 35% reduction in their inpatient stays, and their emergency department visits were cut almost in half. And we did a lot of proactive outreach and touch points, and they could message us at any time. We could get on the phone or video with them. And we did a lot of proactive coaching with these parents, as well as in the moment support. So we found that there was pretty significant value that we were able to generate by doing something that was beneficial to these families. But unfortunately, we didn't have a way to bill for these services. It was really a pilot program, and we were trying to prove the model would work with these results, and then needed to take that to our payers to try to come up with a financial model that would work. Because in the US, we aren't on any sort of value-based payment in general. It's where we want to bring the healthcare system, but currently hospitals get paid when people are sick. So we had achieved these results. We were moving forward with our financial model, and then COVID hit, which really turned the healthcare system on its head financially, and pretty much overnight, the financial landscape of our healthcare system changed, and they made the very difficult decision to stop all programs that were not currently profitable. So this program that was supporting these children ended up getting canceled in May of 2020, which was right when the pandemic was starting to peak in our area, which was really devastating because, these children, that was really when they needed support the most, but we were not able to sustain that program. It wasn't profitable. And so at that point, I was trying to decide what I wanted to do. I felt like we had something really valuable, and I was still working in the emergency department, and I felt like every shift I was seeing patients come into the ER who we had previously kept out of the hospital for 2 years. So my co-founder, Megan, she ran this program with me, and she said, Alison, why don't we try to do this on our own? We know we have something valuable for families and for payers. And we have a model with results. We just need to go do it. And I wasn't so sure about that. I thought it sounded like a really hard thing to do. But we did go ahead and start exploring what it might look like if we wanted to start our own company. And so we really, out of the blue, were contacted by a firm that funds value-based companies and was very interested in pediatrics. They had done a lot of work in the adult space, but felt that pediatrics was a space that was underinvested in, and that there was a lot of opportunity to bring value-based models to pediatrics. And so they actually found this paper that we had published and contacted us about working together to build a company focused on this exact population of children. And so we ended up quitting our jobs and moving our families to a different part of the United States to work with this firm. And we started a company called Imagine Pediatrics, and our foundation was really focused on our vision and our mission, that we really want to be able to bring care to the children who need it most. So all of the patients that we care for are chronically ill. and they are all on Medicaid, which is our federally funded program for patients who are in poverty or are disabled. And so this is a very vulnerable population. And we had very big ideas about what we could do to help these children. So we spent about a year incubating the company. We had an idea that we would put together a medical group that could provide digital, virtual, and in-person care for these children. We don't replace their doctors, but we provide an extra layer of support. And again, we invest in these parents. We invest in teaching them, spending time with them, helping them understand what to look out for, and being there in the moment when anything is going wrong. And so our clinical model, we are a multidisciplinary medical group. Our team is composed of pods of individuals that carry a panel of patients together. So we are based on teamwork and continuity of care. So we have physicians, advanced practitioners, nurses. There are significant social needs in this population. So we have a lot of social workers, and then we also have behavioral health programs and therapists, as well as pharmacists and dietitians. We also have mobile clinicians that can go into the home. And our primary connection point with these families is digital. So we've built our own technology platform, and we have a lot of messaging with these parents, which is a great way for us to achieve scale, but also it's very convenient for the families. And so when they message us, they get a response within 30 seconds from a care team member. We are able to switch to a video visit at any point, and we also do scheduled video visits with them. And then when something is needed in person, we are able to dispatch our mobile team to the home to do additional diagnostics or therapeutics. And with this model, the entire goal is to help keep these children out of the hospital. Again, we don't replace their doctors, but we provide support services, and we provide a lot of coordination across the entire ecosystem of individuals that all care for these very complex children. We've also built in an integrated behavioral health program. We believe very strongly that mental health is health, and for these children to thrive, we need to be addressing both their medical and their behavioral health needs. So we have comprehensive services, including crisis intervention and therapy, all focused on helping care for these children in a holistic capacity. Our mobile integrated care service line is a team of paramedic trained pediatric home care specialists who can do a number of different interventions in the home, but they, in a typical case, if one of our physicians is seeing a patient virtually and they need something in person, we can dispatch that team and then get back on video with our paramedic, who is able to act as our hands and eyes and ears in the home to do further interventions with the patient. We never will do anything virtually that needs an in-person visit, and we're very committed to the highest quality of pediatric care. But with this model, we're able to bring the care to the home and really keep the patient at the center of our model. So I'll share with you some of our early outcomes. My disclaimer is that we started our operations seeing patients in January of this year. So we've only been operating for just over 8 months. We have some early insights, some leading indicators on the health outcomes of the patients, but I'll also share some of our operational outcomes. So we have done a total of 26,000 digital visits, 23,000 virtual visits, and about 600 in-person mobile team visits, which is a total of over 50,000 interactions with these patients. We have risk contracts, so we are responsible for a patient population of about 20,000 complex children across the state of Texas, and we are also in the state of Florida. And on average, the patients who are engaged in our program, we are interacting with them about 5 times per month with our visits, which is, of course, a lot more than the traditional outpatient model. We identify the patients based on a claims-based algorithm that we use with our health plan partners, because we work with the Medicaid plan to identify these patients and then provide our service. Once we identify the patients, we have to go find them, we have to interact with them, we have to get them to interact with us for us to be able to make an impact. And so in the first 8 months, we've enrolled more than 30% of our patient population. And you can see, we're noticing that the longer they're in the program, the more they're interacting with us. Our model is based on trust. And as we're building relationships with these caregivers and showing that we will be there for them, they are utilizing us more and more. We have a leading indicator that we use as a metric to track how often patients tell us that if they hadn't have had an interaction with us, that they would have gone to the emergency department. And to date, at the end of August, we had over 500 incidents where parents told us that their next stop would have been the ER. And historically, since these children are such a sick population, in their past, about almost half of the times that those children have gone to the ER, it's led to an inpatient admission. So we have a lot of indicators early on that this model is working. These patients are engaging with us. We have not had any negative outcomes from the times that we have helped them stay out of the ER. It's always been appropriate. And we've definitely had some cases where we've been able to help get them to the ER, get them to the place that they need to be if they really are having a true emergency, and help really coordinate that care. Our early analysis of our claims data is showing that the cohort that we engaged in Q1 of this year has shown about a 20% decrease in their hospitalizations as compared to their previous year's data. So we don't have the robust analysis that we need to draw conclusions yet, but we have built out an entire research division because we have access to a really significant amount of population health data and can measure which of our interventions are really making an impact. And so claims data through the health plans are often delayed by a handful of months. So as we move through the end of this year and early 2024, we should be able to draw more conclusions about how this intervention is performing. But most importantly is how the parents are feeling and the sort of feedback that we're getting on a daily basis. These parents have carried this burden by themselves for so long. It's so hard for them to access all the things they need, and to have a team of individuals who are available to help them navigate and to really be there when something is wrong has been really a blessing for these families. So as of today, we have 20,000 pediatric lives under full risk management. We are engaging and starting to manage 200 new patients per week. Again, we're interacting with the engaged patients about 5 times per month and have already shown over 500 avoided unnecessary emergency department visits. And so we are growing rapidly. We are having conversations about expanding our model into a number of other states and feel very excited to bring this model to all the children that need it. So I can stop here and take any questions.
Any questions from the room? And maybe while we are waiting for questions, Alison, maybe if you could say a few words as a doctor building a startup. Obviously, there are many business challenges related to that you don't get training in medical school. What are your main lessons learned and tips for doctors that would like to make their idea or care model happen like you are doing it? What's your advice?
So I think I was really surprised at how many resources exist to support new companies with good ideas. And so, working with a firm that was able to provide a lot of the legal support and financial support that was needed to start a large-scale national company has obviously been an incredible blessing. But also kind of getting to know other physician entrepreneurs and understanding what resources they've used. And I can't even remember, Tomasz, when you and I met, but you and I have had talks about, growing a company, scaling a company, and it's a completely different skill set. You're right. We don't learn that in medical school. It's not something that necessarily comes naturally. I had to learn a lot of things about how companies grow and what's important to investors. But I think getting a lot of guidance along the way has been instrumental. And obviously, as someone whose experience is in emergency medicine, I couldn't have done this by myself. I have, an entire group of folks from our firm, and then my co-founders, Megan and Taylor, who are both, extraordinarily skilled in operations and background in finance and technology. It's been, really important to have the input of others, but also recognizing that we as physicians have a very unique viewpoint on healthcare. I never really realized that my ideas about how children should receive care was, a really valuable thing. I've been very interested to see how, the non-medical world, so the finance side of things and the investors and others, really want to hear from doctors. They want to know in your day-to-day, where are the problems? What are the potential solutions? Because our perspective is really important.
I have another question, and if the audience has any questions, please feel free to raise your hand. I'll give. But before I open up to any others, you mentioned that there is a care team. It's not just one doctor. So obviously there is a need for knowledge sharing among your team to know all those patients. How important for you is to know the patients and for the patients to know the care team in the way you're working with, and because in healthcare oftentimes it's like you're anonymous to the system. You're meeting any available doctor, especially in the hospital in an ER setting. But I believe in your situation you're investing in trust, you're empowering the parents and investing in their knowledge of how to manage care. How important is actually this collaboration and knowing the patient upfront for your team?
I mean, it's critical. I think it's what's missing when we see patients in the emergency department, because you need to, especially with these sick children, it's hard to know what their baseline is if you don't know them, and it's hard to know how to treat them if you don't know, what their usual concerns are. And so we do invest a lot of time in getting to know these families. And part of what we do during their onboarding is to ensure that we are making sure that they have everything they need in the home for any of their current action plans. So we're not necessarily creating their plan of care. We're just curating it and educating on it. So if they are supposed to have like a PRN medication that is supposed to be given in certain situations, we make sure they have it and have everything to administer it when they're not sick, so that when they are sick, if they're calling us, we can help walk them through what they need to do. But it's so important to know what these children are like at their baseline. And I can remember a patient that I saw in my former program who was one of our earliest patients who was enrolled. He was a teenager who had a lot of developmental delays, but the first time I met them, it was actually in the emergency department, and his parents came running in with him. They were holding him in their arms, and he was limp and not responding. And we rushed them back to a room. He wasn't really breathing. I started, resuscitating him right away. And his mom was so desperately trying to show me a video on her phone. And I'm like breathing for her child, and we're getting IVs. And she was trying to show me a video on her phone of him the day before. He could walk, he could laugh, he couldn't talk, but he, was a active and beloved member of their family. And, it was only later that I realized, once we got him stabilized and spent more time with his mom, that she felt like, when we go to the ER sometimes, they see his dysmorphic features and they think maybe this is how he always is. And she was worried that we might not try hard enough to save him because of his disabilities, and that we may consider that he's probably always like this, which is not the case. And so that really stuck with me, that these parents, are such fierce advocates for their children, and they have to deal with, discrimination from the healthcare system, and, concerns about how they're going to be treated if someone doesn't know them and care about them and their child. And of course, we treated this patient with the highest quality of care, but I was always very sad that thought had ever crossed her mind. And it must come from experience, where these families experience, care from folks that don't know their child. And so it's so important to us to have that continuity, so that we have that relationship and trust, and that we are able to really help these families, because so much of what needs to happen is they need to be compliant with their care plans, and we need to know what sort of symptoms their child is having to see if their care plans need to change. And the other really critical component is for us to have really great communication with the whole network of physicians that cares for these children, because so often their care can be siloed, and the neurologist is only thinking about, the neurologic system, and the gastroenterologist is thinking about their feeds. And it's sometimes hard to get the whole network to work together.
Amazing. Thank you very much. Maybe last question before we will need to move on. What do you see as the potential of AI or prediction or data in general to support your work in the future while you're tracking so many kids and supporting them and taking full responsibility for their continuity of care? So they are not new kids when they come to your ER. You continuously gather data about them. What do you see? How could AI or new tools support your work?
Yeah, so I see a lot of potential applications. So on the one hand, some of what we're thinking about is how we use AI to help us, say the right things to families. So when we're reaching out to them and really want to help them to use us as a service, they can be kind of suspicious sometimes. They've been treated poorly by the healthcare system, and they want to make sure we're not a scam. And so there's some scripting prompts and things that there are some programs that we're looking at that can help us to really address parents' concerns and needs in the moment as our outreach team is trying to really help these families understand what we do. Also, the documentation burden in healthcare in the U.S., I don't know what it's like in Poland, but in the U.S., I feel like our clinicians in a traditional setting spend almost half of what they do is writing down what they do. And there's a lot of significant administrative burden to the practice of medicine. And so there's new technologies that you can use to basically record the visit and in writing and write the patient history for you as you're having the conversation. And that sort of tool can help the physician really be able to focus on the patient and be in the moment, focus on the person that they're talking to rather than focusing on writing down everything that they say. So that's another application that we're looking at. And then finally, with the data sets that we have full claims and financial data on 20,000 patients who we are actively doing interventions on. What we would love to understand is how do we identify from a predictive analytics perspective which children are at risk for decline, which ones are at risk for potentially going into the hospital, and how can we catch those things early and use our data to do that? Because right now, we're really focusing on the parent perspective, but I do believe there's things within their health data that can help us determine who's the highest risk. So those are just some of my ideas.
Super. Thank you very much, Alison. Thank you for joining us, and all good luck. I hope that your service one day will be global. So wishing you all the best, and thank you very much for joining us.